Welcome to day 2 of WiDS Philadelphia at Penn. I hope you'll enjoy the talks as well as the networking opportunities using Gather.town. I was wandering around in that space and it was pretty fun. My name is Susan Davidson and I'm a professor of computer and information science in Penn Engineering and also the co-faculty director of the MSc in data science here at Penn. I'm also organizers of this event, WiDS Philadelphia at Penn, which is a partnership between Penn Engineering and Wharton and coincides with the annual Global WiDS Conference held at Stanford with an estimated 150 plus organizations worldwide. The theme for Penn's conference this year is this is what a data scientist looks like. Now, of course, because of the pandemic, this year the event is being held virtually as a serialized week of programming every day from 12 to 1. Tomorrow, when you join us, if you join us, you will hear from a panel of industry experts sharing their professional journeys and career advice for future data scientists. Today, you're going to hear about experts in 2 different data domains, radiology and imaging data, and social and network data. Our first speaker, Dr. Tessa Cook, is an assistant professor of radiology at the Perelman School of Medicine here at Penn, and she does both clinical work as well as research. Her research interests include radiology informatics, artificial intelligence, practice transformation, and radiology education. She serves as the fellowship director for the Penn Radiology Informatics Fellowship. Her bio can be found in the program, and she will be speaking to us today about current applications of data science, radiology, and imaging informatics, and she'll point out some hot topics and unsolved problems. Our second speaker, Professor Betsy Ogburn, is an associate professor in the Department of Biostatistics at Johns Hopkins University and is the founder of the COVID-19 collaboration platform. Her research is in causal inference and epidemiological methods, and a major focus of her work is on analysis of social and other network data. Her bio can also be found in the program. She will be speaking to us today about social network dependence and how using traditional statistical methods for social network research questions is problematic. They do not adequately account for network structure. The talks have been pre-recorded and will be played back to back. You're encouraged to submit any questions that you have throughout the event chat function. The speakers who are here online with us may answer them online, as well as during the live event at the end of this session. And then there will be further networking opportunities for 30 minutes after this session using Gather.town. And I've talked about this twice. If you don't know what it is, please check your daily welcome email for details or reach out to Maddie Lesser, whose email is also listed in the daily welcome. Point out that in addition to the entry room and auditorium, our virtual conference space has a sponsor room where you can find more information about the sponsors of this event. So, without further ado, let's hear from our speakers.
Hi everyone, I'm delighted to be here with you today to talk about data science in radiology and imaging informatics. My name is Tessa Cook. I'm a radiologist and informaticist at the University of Pennsylvania. I have some disclosures, mostly related to leadership roles that I hold in a variety of radiology organizations, some grant funding, and some departmental vendor agreements related to AI research. So you might be wondering why a radiologist would need data science. And so I thought it might be helpful to start with a little bit of a background of what a radiologist does in the course of a workday. For most of us, we are diagnostic radiologists who spend our time interpreting images in the context of the patient's clinical history and providing information in the form of an interpretation of those images that can be used to guide management, perhaps surgical planning. But many of my colleagues are also interventional radiologists who perform image-guided biopsies or sometimes image-guided targeted therapies. But in addition to our specific clinical functions, we also spend a lot of time in consultation, sometimes with other colleagues, one-on-one, to guide therapeutics or management of patients that are currently in the hospital, or for outpatients who might be awaiting surgical procedures. We also consult with our technologists who are actually performing the imaging and running the equipment directly. And in some cases, even with patients, again, as part of planning the next steps in their care. So for as much time as we spend at the workstation, we also spend a fair bit of time in discussions with other members of the care team and with patients directly. For me, as a cardiovascular radiologist, my role is almost exclusively diagnostic. I don't really do very many procedures. And my clinical area of interest pretty much covers blood vessels from the lower part of the neck all the way down through the toes. And so any organs that we see along the way are also our responsibility. And that really equates to, in some cases, thousands of images for a single patient multiplied by dozens of patients over the course of a day. So at the end of the day, that is a large quantity of data. So again, even after that description, you might still be wondering, so why does a radiologist and why does the specialty of radiology need data science? So it turns out that we generate a ton of data in the course of routine clinical practice. Some of it is easy to see, images, obviously, the reports that accompany them. Some of it's a little bit harder to capture, measurements, changes over time, particularly in measurements, and then even imaging textures, so things that we can appreciate with the human eye, but not necessarily quantify as easily. So what happens to all of this data after we generate it? Where does it go? How is it processed? How is it analyzed? This is why we need data science. And really, this was the reason for the birth of imaging informatics. So imaging informatics is this marriage of information science, healthcare, and computer science, and it has to do with the practice of processing information, engineering of information systems, and that human-machine interaction and interface for all of the different systems that we interact with over the course of a day to provide clinical care. So it turns out that radiology practice wasn't always this complex and this data heavy. And so you have to go back a little bit of time to actually find out what led to the development and the need for imaging informatics. If you go back in time a few decades, radiology was mostly X-ray and fluoroscopy, which is effectively dynamic X-ray. And even though the images were generated in a digital format, they were then converted to an analog format. And so actually printed out on film, and it was those films that the radiologist would then interact with for their diagnostic process. So early in the 1970s, the first head CT was performed on equipment that you can see here that is now in the Science Museum in London. A few years later, the first body CT was performed, and that was when radiologists started to deal with a little bit larger quantities of digital data. So if you look at the late 70s, Dr. Heinz Lemke, who is a computer scientist in Europe, published this paper where he talked about this concept of a medical workstation. So a way that radiologists could interact with data without necessarily being in the same physical location where that data was acquired. In other words, in the room just outside the CT scanner where the computer running the scanner was located. And so this was the earliest description of something that ultimately became our PACS, or what we call our Picture Archiving and Communication System. PACS, the official term, was coined back in 1982, but this has really become the workhorse of clinical radiology today. In many parts of the world, there is no more film that's used in radiology, and what we use instead is PACS that allows us to connect all the different kinds of imaging equipment that we might use to get the exams off of the equipment into this central archive and then distribute them to the physicians that might be scattered all around the country in some cases who need to be able to view them and interpret them. And so Imaging informatics, it really started with imaging data, but now is so much more than just images. If you look at this word cloud of what the areas of priority are for imaging informatics fellows who are completing their training today, you'll see the word images in there, but it's not very big. And there are so many other concepts that are central to the field now. And it's, as a little side note, it's really one of the reasons that when COVID hit last year, that radiology was able to pivot, because this infrastructure for remote practice and virtual teaching was already in existence, even though it wasn't heavily used. But it gave us that ability to be able to maintain our practice, even if we weren't physically all present in the same location. So let's talk a little bit more about where data science and imaging informatics come into play in clinical practice, but also in other areas of healthcare. Even beyond radiology, medicine today just involves tons of data moving in all directions. And almost everyone now has an electronic medical record thanks to meaningful use and the health incentive programs from the Office of the National Coordinator that are now a little over a decade old. EMRs were originally designed to drive medical billing, not as patient charts. And so that adaptation kind of came a little bit later. And in part, this is why it's easy to get data, or easier at least, to get data into the medical record, but not nearly as intuitive to get it back out. In radiology, since PACS, we've always had tons and tons of data. But as I mentioned earlier, there are actually some data elements that are a little bit harder to capture and use in the course of daily clinical practice. And so there is this burgeoning field of radiomics, using those textures within the image, those primary and secondary imaging features, to actually make correlations with diagnosis, with prognosis, with outcomes, to make choices for therapeutic approaches based on these additional imaging characteristics that, although they're not visible to the human eye, represent large quantities of previously untapped data. One of the challenges, though, is that all of this data is not always easy to access in all of the different systems from which we might want to get it. And so this is one of the biggest roles in imaging informatics, is making sure that our data moves around correctly. And a great way to appreciate this is to actually think about the life cycle of the radiology report. So from the time that someone orders a radiology exam to the issuing of the final interpretation. And you'll notice this is somewhat of an older figure because there are many paper-based steps in this workflow. If you start all the way on the left at patient registration, before you get all the way around to the end of the process with imaging review and interpretation, you'll notice multiple intermediate steps at which digital data perhaps gets converted to an analog format for transfer to the next phase. And so this was not surprisingly somewhat of an error-prone process, and there were those transitions were chances where data might get corrupted or lost. And so as part of this particular effort, which I'll tell you about more in just a second, the goal was to maintain the consistency of patient information as it transitioned through the care process, understanding that fewer errors would mean better patient care and increased efficiency. And so now, if you study this process, you'll find that, in fact, there are so many more standards that are associated with different aspects, with all of these manual analog transitions now becoming electronic transfers of data over the course of the care process. And so this is really the reason why the need for standards became very important in radiology, because we have so many different kinds of data and so many different transitions of data in the course of routine clinical care, and it became very important that the integrity of that data, the accuracy of that data was preserved. So we needed a way to communicate effectively, maintain the order of the data, set expectations for what kind of data was coming through, and have a seamless and valid exchange of information. So there are imaging standards and non-imaging standards that we interact with frequently, and there is an organization called IHE. It's an international initiative called Integrating the Healthcare Enterprise. And the goal of IHE is to help us figure out the best way to apply these standards. And now there's always a common joke about standards because sometimes they might conflict, and in order to address that conflict, we just make more standards. And that life cycle sort of repeats itself. But in order to avoid that, we have the work of the IHE Initiative, and their role is really to guide the development of tools that can increase the interoperability of health systems to improve data exchange and to use established standards, not to create new standards to address these problems, but to use the standards that we actually have. And they provide technical frameworks, and they also provide implementation guides to vendors, which is really helpful because then a vendor who builds a solution with one of these implementation guides along the way can actually build something that is interoperable and can interact with other solutions that have been built against the same technical profiles. So we've talked a lot about how much data there is and how it's moving from one system to the next during routine patient care. But what if you want to extract that data for operational analytics or quality improvement or research or innovation? And if any of you have been in a position to have to do that, you may have found it a little bit challenging. And the truth is, because our data is stored in different systems, it can be challenging to get at the data that you want for one of these efforts that isn't routine clinical care. And so part of the challenge in that is that different sources of data live in different places. You might want data from the medical record, you might want data from the billing record. You might want imaging data, or at least radiology data, whether that's actual images or reports or something else. And oftentimes these data are stored in systems that don't always speak to each other, that may have patient identifiers that have to be reconciled so that you know that you're getting the right data for the right patient. In some cases, the schema for these systems are not very evident, and so although you may be able to get the data out, you're not necessarily sure what it means or what is stored where. And for as much informatics is happening behind the scenes during patient care, there's just as much that's happening to support research and development and quality improvement. And the other big challenge that we encounter is even though some of the data is structured, for example, laboratory results and things like that, a lot of it is not. Radiology reports, for example. And even the structured data may not be stored in a way that is easily understood. And so, at least in radiology, to address some of these issues, we've had a lot of development. There's something called the Radlex Radiology Lexicon, which is, in fact, an ontology of terms. So terms and their hierarchical relationships to one another that have been mapped out not only for terms that we would use in a narrative radiology report in an interpretation of an imaging exam, but also in the naming conventions of those different types of studies. And so there's been a lot of work here to try to create structure in a way where there previously wasn't. In addition, for the actual interpretive process itself, there's an effort underway to create templates in a template library to try to standardize the approach to actually interpreting some of these exams. And taking that even one step further, there's an initiative surrounding the development and definition of common data elements. So I mentioned measurements earlier in the presentation, and the measurements that we typically generate in a radiology report are just stored as part of the narrative. And so if you want to try to extract these to do any kind of analytics, it becomes very challenging. And so the Common Data Elements Initiative is really intended to try to create discrete data elements that store this discrete data, such that you can directly query those specific values without having to extract them from a larger narrative. Now, I'm a radiologist, so in all fairness, I've spoken a lot about radiology. But imaging happens all over a healthcare enterprise, and not all of it is stored in the PACS, which, as I mentioned, is the workhorse of radiology. And so there's a large initiative around enterprise imaging about being able to store all of the imaging that is done in a distributed healthcare network and deliver it back to the consumers of that data in a fashion that they are most familiar with or most comfortable with, but also making that data available across the enterprise to providers and physicians that may not necessarily be in the same physical location. And so not surprisingly, this requires a lot of infrastructure, this requires a lot of governance, this is large quantities of data going back and forth across a system that need to be made accessible, sometimes in different viewers and on different platforms. And so this is an enormous undertaking, but a very valuable one for integrated delivery networks that actually take this on. I would be remiss if I said nothing about artificial intelligence at some point in this presentation. So I will conclude with a few comments on AI in radiology. A little over 4 years ago, there were some dire predictions made about the future of my specialty that suggested that radiologists were like Wile E. Coyote, who had already cleared the cliff but just hadn't looked down yet. And the more that we started to look at the role of AI in radiology, the more we started to realize that AI was not just going to be replacing all of us, as the prediction would have suggested. If anything, what we've started to discover is that radiology and AI together actually has the potential to help us deliver better patient care. In some ways, it's like the new imaging modality. You know, the generations of radiologists before me had to figure out how to use CT and MRI and molecular imaging for their patients. And my generation and the next generation are going to have to figure out how to use AI to figure out what it does, more importantly, what it doesn't do, and how we can use it safely and effectively as we deliver patient care. There are so many potential use cases for imaging AI. The most common ones that people talk about have to do with pixel-based data, with image data. But in fact, radiology, or AI, has the potential in radiology to do a lot of things that humans are not very good at, like searching through the medical record, making sure that we're consistent. There are a couple of really interesting and exciting potential use cases. For example, being able to predict future development of disease based on the appearance of imaging today. And so this technology is going to be around for a while and it's going to be developing for quite some time. It's really very early. And so it's going to be exciting to see what we can use it for and how we can use it. One of the criticisms of AI is that it is a little bit of a black box. Data goes in, some conclusion comes out, and you're not really sure how it all happened. And so explainable AI is a very active field right now in trying to figure out how to make the conclusions and the decision points of an AI model more evident to the end user. There's a very nice multi-society statement on the ethics of AI in radiology that I was honored to be part of as a co-author. And in this paper, we say that the transparency, interpretability, and explainability are necessary to build patient and provider trust. You know, for us as physicians, this is new technology. We need to be able to understand how it works to make sure that it's working correctly and that it's safe for our patients. The other big consideration is the data. So much of building a good AI has to do with making sure that the data chosen to train the model represents the problem that you're trying to solve. There are challenges in getting expert labeled data, how much data is needed to build a good AI model, and a lot of focus on potential bias that can be introduced into AI models, intentionally or otherwise. We've seen this in non-medical applications of AI, where the population to which the AI is applied is not representative of the population with which of the data with which the AI was trained, and it can produce some very spurious results because of that. If you extend that to healthcare, where you're talking about patients' lives, there are potential real consequences and really devastating consequences, and so we have to be very careful about making sure that we don't introduce bias into these models that we then deploy clinically. Figuring out how to put AI into the workflow is something that we are all actively thinking about and working on right now, because no two radiology workflows are the same. It's really not a one-size-fits-all kind of process, and therefore you can't just take one AI and say, okay, this is going to work the same way for every user. And so this is a real challenge for our colleagues in industry, but one they are rising to in trying to figure out how to make this a solution that works for the radiologist rather than the other way around. This is a very provocatively titled article in the Journal of the American College of Radiology, but I really like to mention it because I think it's the most honest appraisal of AI right now. Is it a threat? Yes. But is it an opportunity and really an opportunity for disruptive innovation? Absolutely. And it's really requiring us to rethink how we deliver care, and I don't think that's necessarily a bad thing. Because at the end of the day, the goal is not to build a robot radiologist. It's to take those tasks that don't require an MD or don't even require a human and automate them so that the expert physician can have these additional tools to supplement what they already are able to do well. And there are so many potential use cases, as I mentioned, and I think really an opportunity to help us be more effective and more efficient by offloading to the computer the things the computer does well to allow the human to do what the human does well. And although it is certainly more exciting to paint this sort of human versus machine adversarial approach to radiology AI, I think really what we're going to see is a much more collegial and cooperative future where the technology augments the expert physician reader rather than replacing them. And so to conclude, healthcare is so different than it was even 20 years ago. You know, we generate more data in routine clinical practice than we ever did before, and radiology contributes a great deal to this. We're heavily dependent as a result on data science and imaging informatics to manage this data, organize it, and analyze it in a meaningful way to guide patient care, but also to advance research and innovation, maintain quality, and teach the next generation, both of radiologists, informaticists, and data scientists. And so I really appreciate the opportunity to speak with you all today, and please reach out if you have any questions or if I can be of assistance in the future. Thank you so much.
Thanks so much to the organizers for putting together this fantastic conference, and I really appreciate the opportunity to speak to you today. I'm going to talk about social network data and the dependence underlying this kind of data and problems that can engender for statistical analysis and inference. So this is a picture of a social network. When I talk about network data in this talk, what I have in mind is that from each node or each person in the network, we have observed some variables, covariates, treatments or exposures, outcomes. I don't mean data about the network structure, which is what network data often means. This particular network was created using Framingham Heart Study data, and I'll come back to describe the Framingham Heart Study in a little bit. When subjects in a study are connected to one another by social network ties, as they are in Framingham Heart Study, it can engender dependence. Their data can exhibit statistical dependence, and that's what I'm going to talk about today. So I'll use the Framingham Heart Study as a running example and tell you a bit about that study first. Then I'll explain two things that can go wrong when researchers analyze data without fully accounting for the dependence in the data. The first is anti-conservative statistical inference, and the second is spurious associations. And I'll explain what I mean by those terms when I get to that. Then I'll talk about a test for dependence that my fantastic former student, Eugen Lee, developed that can provide circumstantial evidence for when these two problems might occur. And I'll tell you about what happened when we applied this test to several highly cited published papers that use Framingham Heart Study data. And finally, I'll describe how I reanalyzed one particular Framingham Heart Study paper's analysis. And in the reanalysis, I accounted for dependence. The original analysis had not accounted for dependence. In the reanalysis, we found no evidence of the strong effects that the original paper had purported to find. The Framingham Art Study is an ongoing cohort study that was initiated over 70 years ago. It's one of the most influential modern epidemiologic studies, and it's arguably the most important source of epidemiologic data on cardiovascular disease. Thousands of publications on cardiovascular disease and other types of health outcomes have used Framingham Art Study data, and they continue to be published. Hundreds of new papers are published using these data every year. And just about all of these papers, all of the papers that are not explicitly about genetic relatedness in the Framingham Art Study cohort, all of the papers use IID statistical methods. IID means independent and identically distributed. So all of the papers published using these data assume that the subjects are independent. But when you look at who's in this cohort, you see that they're really interconnected with one another. So the subjects in the Framingham Art Study comprise a significant portion of the residents of a relatively small suburb of Boston in Massachusetts, the city of Framingham. The subjects are neighbors and friends and coworkers with one another, and they're related to one another. There are about 1,500 extended families that have at least 3 members participating in the study. This makes Framingham Art Study a perfect, though probably not unique, example of a convenience sample that's comprised of members of an interconnected network rather than independent subjects. So Framingham Art Study might be especially interconnected, but convenience samples that tap into social networks are actually very common in the health and social sciences. For example, psychology studies that recruit undergrads from a single university, education studies that recruit subjects from one or a small number of schools, medical studies that recruit subjects from one or a small number of hospitals, and any study that recruits subjects from one or a small number of communities could fall into this category. And these convenience samples are always analyzed using, again, these IID methods that assume that the subjects are independent. So what I hope to convince you of today is that ignoring the dependence in this kind of convenience sample can lead to the publication of spurious results, and that this could be an important cause of the replication crisis. But in all of the soul searching about the replication crisis in psychology, social science, public health, medicine, the role of inadequately handled statistical dependence has been pretty much entirely overlooked. Framingham Art Study also plays a really important role in the study of causal effects in social network data, specifically peer effects, or the causal effect that one person can have on their social contacts. In the early 2000s, Nicholas Christakis, a sociologist, and James Fowler, political scientist, realized that buried in the Framingham Art Study data, which again is a cardiovascular disease epidemiology study, but buried in the data, there's a ton of information about social ties, about who's related to whom, who's friends with whom, who works with whom, who lives near whom. So Christakis and Fowler harnessed this information to create the network picture that I showed. They looked into the records and put together a picture of who's connected to whom in order to be able to create that network. And then they published a series of extremely influential and highly publicized papers looking for evidence of peer effects for lots of different outcomes in the Framingham Art Study data. And this initiated a lot of interest in using similar methods to estimate peer effects in social network data, both using the Framingham Art Study social network and other non-experimental social network data sets. Over the years since these papers started coming out, statisticians have criticized the methods for a variety of issues, but the problem that I'm most interested in has received very little attention so far, and that's the fact that the methods used in all of these papers to learn about peer effects assume, again, that the data are independent. And this is despite the fact that peer effects are themselves a form of social network dependence. So most of what I'm going to talk about comes from this paper that was led by my former student, Yu Jim. And first, let me explain why it's a problem to treat data as if they're independent, to use methods, statistical methods that assume data are independent, when in fact there's some dependence in the data. So first off, failure to account for dependence in your data is a problem for uncertainty quantification. Statisticians use standard errors and confidence intervals to quantify the statistical uncertainty around an estimate. And p-values are also, in some sense, a measure of this uncertainty because the p-value of an estimate depends on the estimate standard error. We say that a method is conservative if you overestimate the uncertainty, and this is generally a desirable property. This protects against type 1 errors, which are claiming that an estimate is statistically significant when you shouldn't make that claim. Any intermediate level course in statistics will teach you that ignoring most kinds of dependence will lead to underestimating uncertainty, and this is anti-conservative inference. When you underestimate uncertainty, you're too confident in your results, and so you might publish claims of significant effects that might not actually warrant that label. And of course, if an effect should not be called significant and you publish it as if it is, then it may not replicate as expected. So even though this is a really known statistical fact in the abstract, it's not that widely known in applied statistics, and it hasn't really been connected to the replication crisis in any widespread way. And I hope that I'll convince you that it's something that applied researchers need to be more worried about. And in fact, those of us who work on statistical methods need to be more worried about it as well. So that's anti-conservative inference, and it can affect any kind of estimation. If we're specifically interested in estimating the association or a correlation or a causal effect between two variables, let's say x and y, and if both x and y exhibit similar patterns of dependence, then even if x is independent of y, if we fail to account for the dependence within x across network nodes and within y across network nodes, then the dependence can give rise to spurious association estimates. This means estimates that are concentrated away from the true value. Okay, so let's dig into these two problems and try to understand exactly why they occur. So first, I'll explain the problem of anti-conservative inference. Why does ignoring dependence lead to underestimating the uncertainty in an estimate? Suppose we want to estimate a simple mean, like the average height of people living in the Boston suburbs. And we'll use the sample average of height measurements from the Framingham Art Study as our estimator. If you've ever taken a statistics class, you'll probably know this formula. The variance of a sample average is sigma squared, which is the variance of a single observation, divided by n, which is the number of observations in our sample. So in this case, it would be sigma squared, the variance of height in the Framingham Art Study, divided by n, the number of people in the Framingham Art Study. Well, what if we use sigma squared divided by n as our variance estimator when, in fact, the data are dependent? The true variance is in this last line here, and the red term is what's missing from the standard variance estimator that assumes the data are IID. It's the pairwise covariances for heights among everybody in the Framingham Art Study. And whenever this term in red is positive, the true variance will be greater than the variance that assumes the data are independent. And that's the estimate, again, that you would use if you weren't worried about dependence. So ignoring the dependence underestimates the variance of an estimator. One way to think about what's happening here is that we use the variance of an estimator to quantify how much information the estimator has about the parameter we're trying to learn about. So the amount of information that we have in data is related to the sample size, the number of observations in the data. The larger the sample size, the more information we have. Typically, we think that each new data point brings one new bit of information to our estimator. But if data are dependent, then in fact, each new observation is bringing some new information, but not a full bit, because some of the information in that new observation is redundant due to the dependence. So each new data point is bringing less than one new bit of information. This is related to the effective sample size of a dependent data sample, which is less than n, the number of observations, because we have less information about what we're interested in estimating from a dependent sample than we would if we had the same number of observations, but they were independent. So I just explained why ignoring dependence can lead to anti-conservative inference, that is, to confidence intervals that are too narrow, p-values that are too small. Now let's turn to spurious associations. Suppose we're interested in the association between some variable x and some other variable y. If there's network dependence in the x's, and there's also network dependence in the y's, then there can appear to be an association between x and y even when x is independent of y. So as a toy example, let's say that x is height in the Framingham Art Study and y is political orientation in the Framingham Art Study. Spurious associations arise because two people with similar x's are more likely to be close in the network. So if x is height, two people who have similar heights might be more likely than a random sample of two people to be familially related, genetically related in Framingham Art Study. So similar x's means you're more likely to be close in network distance, and being close in network distance means that you're more likely to have similar y's. So people who are connected in the social network are more likely to share the same political views. But that doesn't mean that height is related to political views. It's totally an artifact of the dependence. So in an analysis, it might look like, for example, being tall is related to being progressive, but this is only an artifact of the statistical dependence. And if you go to a new network, we might expect again that height and political orientation would appear to be associated, but the direction could be totally flipped. So in a new network, it's just as likely that being tall will be associated with being conservative instead of being progressive. This kind of problem of spurious associations due to a shared dependent structure that's similar within the x's as it is within the y's is really well known in the literature on time series, where it's known as spurious correlations or sometimes nonsense or volatile correlations. And I think this is also really similar to a phenomenon known as confounding by batch effects or confounding by population structure in computational biology and in statistical genetics. Even though these phenomena are called confounding, I would claim that what's really happening there is spurious associations due to dependence. But even though these spurious associations can arise whenever data are dependent, it doesn't matter whether it's time series or spatial or genetic or network dependence, this phenomenon hasn't really been discussed in a general way outside of the time series or the comp bio literature, as far as I'm aware. And just like anti-conservative inference, spurious associations could contribute to the replication crisis. If I wrote a paper claiming strong evidence from Framingham Art Study that being tall predicts being progressive, this would very likely fail to replicate. So to illustrate in simulations, these are histograms of a correlation coefficient for two variables, x and y, where Eugen again simulated x to have network dependence and y to have network dependence, but in all of these simulations, x is independent of y. So that means the correlation should be 0. In this first blue plot, the data were actually IID. There's no network dependence, and you can see the correlation coefficient is really tightly clustered around 0. As we introduce more dependence, that tight bell curve around 0 spreads out, and at first it looks like maybe this is just a problem of increased variability, the problem that I described when I was talking about anti-conservative inference. But the real hallmark of spurious correlations is that when you introduce enough dependence, you get the picture in this last plot, plot D, where you can see the correlation coefficients are concentrating away from 0. They're not just more spread out but peaked at 0, they're actually concentrating at the extreme values of 1 and -1. Okay, so at this point, I hope I've convinced you that treating dependent data as if they're independent can lead to drawing spurious conclusions, publishing spurious results, which might then fail to replicate. But this leaves open the question, are data from convenience samples like the Framingham Art Study actually dependent in a way that could be problematic? So just because people are connected by social network ties doesn't mean that there's strong or problematic dependence. It also doesn't mean that every variable that we might be interested in would exhibit dependence. So to try to get a little closer to what we really care about, which is how problematic is this for real data analyses, Eugen developed a test for network dependence that's based on Moran's I, which is a really popular test statistic for spatial dependence. We then applied this test to 6 published papers that used the Framingham Art Study data. For each paper, we first reproduced the analysis in the original paper. Then we tested for dependence in the regression residuals. So if you've taken a regression course, you may remember that the errors or the randomness around the fitted regression line are supposed to be independent. And if we find evidence of dependence instead in those residuals, we interpret this as circumstantial evidence that inference that relies on the assumption of independence might be anti-conservative. We also tested for dependence in the primary predictor or exposure of interest and in the outcome of interest. And if we found evidence of dependence in both the exposure and the outcome, then we took this as circumstantial evidence that the analysis could suffer from spurious associations. I'm saying circumstantial evidence because we really don't have a good way of linking finding evidence of dependence to just how wrong results in the published literature could be. So these are just, this finding evidence of dependence suggests it was wrong to use models that assume the data are IID, but it doesn't tell you whether the conclusions themselves are incorrect. So first I'll tell you about 5 papers from the medical and epidemiology literature. So Eugen did a Google Scholar search and essentially picked the first 5 hits that were reproducible, meaning we could figure out from the text what analysis the authors ran, and the analysis relied largely on the publicly available portion of Framingham Art Study data. And what we found really surprised us. We expected to find some, but not overwhelming evidence of dependence. And in fact, we found extremely strong evidence of dependence in every analysis from 2 of these papers, the Lauer et al. And Suchi et al. Papers. And in the other 3 papers, we found a mix of evidence of dependence in some of the analyses and inconclusive evidence in some of the analyses. So in none of these 5 papers did we fail to find any evidence of dependence, and that was really surprising. Obviously, this is a tiny fraction of Framingham Art Study papers, but it suggests that much of the research coming out of Framingham Art Study could be misapplying models that assume independence to dependent data. And this, again, suggests that it's possible that results could suffer from artificially inflated certainty, meaning artificially small confidence intervals and p-values, and also spurious associations. But again, I just want to give the strong caveat that this is only circumstantial evidence that the actual results themselves could be spurious. Then we took the paper that arguably launched a movement of interest in studying peer effects using network data. This paper purported to find evidence of peer effects or social contagion for obesity. So to assess whether there are peer effects for obesity, the authors ran pairwise alter ego regressions. The ego is the person who furnishes the outcome for the regression. It's the person whose obesity we want to explain. And the alter is one of their social connections. So every directed edge in a network corresponds to one alter ego pair. These regressions, which have one entry per edge, regress an ego's obesity indicator at time t on their alter's obesity status at time t-1. And they control for both the alter and the ego's past obesity and for baseline covariates. What's most important to note here is that each alter-ego pair in the regression is assumed to have independent errors. So this assumes that each edge in the network is independent, even though the same node can be the ego in multiple pairs, and even though the data comprise multiple extended families. So there's strong scientific reasons to suspect that the errors might not actually be independent here. And sure enough, when Yujin ran her tests of dependence, she found very strong evidence of dependence in the exposure, the outcome, and in the regression residuals. In a different project, my colleagues and I developed a method to estimate causal effects using non-experimental social network data that accounts for some of the dependence that we would expect to see in a network, although this method is by no means fully general to all of the different types of dependence we could see in networks. And when we reanalyzed the Framingham Art Study data to look for peer effects of obesity using these new methods, we found no evidence of peer effects. So the first thing that we did was to reframe the question. Instead of treating each alter ego pair as a separate line in the regression, we came up with a version of peer effects that can be defined simultaneously for all of the nodes in this interconnected network. And that was to estimate the expected change in an ego's obesity status if we were to increase by 1 the number of their alters who meet the criteria for obesity. On our estimate, which was on the additive scale here, was exactly 0, so exactly the null value, and it has a pretty narrow confidence interval. We also estimated a slightly different causal effect, so the causal effect of increasing the average BMI among an ego's alters by half of a standard deviation, which is 2.2 in the units of BMI. And again, we estimated this causal effect to be indistinguishable from 0. So our analyses, which account for network dependence, are not consistent with the presence of peer effects for obesity, but they are consistent with the conjecture that the original paper could have suffered from spurious associations or anti-conservative inference due to overlooking dependence across the nodes in a network. So in conclusion, whenever data are dependent, analyses that treat the data as independent or that fail to fully account for that dependence can underestimate uncertainty. So that means they underestimate standard errors, have p-values that are too small, and have confidence intervals that are too narrow. And they can also produce spurious estimates of associations and of causal effects. And data might be dependent more often than we think. Convenience samples are everywhere in the health and human sciences. Whenever researchers recruit subjects from one or a small number of communities or schools or hospitals. Not to say that every time researchers use a convenience sample, their analysis will be flawed. We actually have no idea how common this is beyond Framingham Art Study. I forgot to mention, but our test of dependence requires that you know something about the network structure. And that's almost never the case with convenience samples. It's only thanks to the amazing work of Christakis and Fowler to reconstruct the network underlying Framingham Art Study that we're able to test for dependence in that particular convenience sample. I've primarily focused on how these problems could contribute to the replication crisis in the health and social sciences, but spurious associations are also a problem for any out-of-sample prediction. So this means that machine learning practitioners need to worry about using convenience samples or other kinds of dependent data for as training data. And finally, I'll just close with a plea for more people to work in this area. So statisticians know how to account for lots of kinds of dependence, specifically Euclidean dependence. So dealing with spatial dependence and temporal dependence, that's dependence in Euclidean space of dimensions 1 and 2 are, and also spatial temporal dependence, so that would be Euclidean distances in 3 dimensions. Those are very active areas of research. But network dependence is non-Euclidean, and dealing with this kind of dependence is really a new frontier in statistics, and adequate methods to account for network dependence in full generality just don't exist yet. So a lot more research is needed in this area. And with that, I would like to thank my collaborators, and Eugen Lee and Oleg Sofragin are the 2 primary co-authors on the work that I presented today. And then this work was funded by the Office of Naval Research Mathematical Data Science Program. Thank you very much.
Thank you very much.
Thank you so much, Tessa and Betsy, for these 2 excellent talks. I know that there have been a number of questions that you've been answering in the chat window as well as in Q&A. So since our time is running out, I'm going to ask each of you just one question, and I think that I'm going to start with Betsy. So Betsy, what recommendations would you make for researchers who are designing data collection but don't have the resources to avoid some of the aspects of convenience sampling?
That's a great question. I think I would first recommend thinking really hard about what kinds of dependence would affect the variables that you're actually interested in studying. And so, if it's something that might exhibit genetic dependence, you can try to make sure that your convenience sample doesn't include people who are genetically related. If it's something that might exhibit like peer influence kind of dependence, you can make sure that the people in your convenience sample aren't friends. And then the other thing you can do is collect a little bit of information about how the people in your convenience sample know one another, and a little bit of information about the underlying social network, and that will at least allow you to test for dependence. But I think through careful study design, it's usually possible to avoid the most problematic kinds of dependence. You just have to be aware of it up front.
Great, thanks. And Tessa, there's been some super interesting questions about privacy in your chat, which I personally would love to follow on with, but there was another question that came up, which I would love you to address also, which is what kinds of barriers, if any, have you experienced as a woman in data science and radiology?
That's an interesting question. So I have a little bit of a unique background in that I was an engineer through most of my preclinical training. So I got my bachelor's and master's degrees in biomedical engineering. I also got a bachelor's in computer science. And so I think I took a little bit of a different route perhaps than most who are now in radiology, and I'm sort of used to being the only woman in the room, or one of the only women in the room. And I think that has certainly influenced my experiences on the clinical side as well as on the informatics side, because I'm happy to say it happens less often than it used to, but it still occasionally does happen that I'm one of the few women in the room. And I think for me, I was just sort of used to it, if it's sort of sad as it sounds. But I think that influenced my experiences. And so I don't know that I encountered as many barriers, just partly because I sort of expected it to be that way. But I will say that, one of my roles now is as a fellowship director in imaging informatics. I obviously work with a lot of residents clinically, and in my work with multiple radiology societies, including the Society for Imaging Informatics and Medicine, we're constantly trying to nurture the next generation, and particularly we know that something happens, right? And at the elementary school level, I mean, by the time people come to us, in graduate school and medical school, that kind of dichotomy between why suddenly little girls who are interested in science and math aren't anymore has already happened. And so we're really trying to focus on the next generation and trying to make ourselves more accessible for others to see that they have role models in this space, and come be one of us.
Great. Thanks so much. I think we're all with you there, Tessa. So thank you both again for spending time talking to us, and both super interesting. I have a billion questions, but I'll have to do it afterwards, as will everybody else. So on behalf of the WiDS 2021 team, I want to thank everybody for attending this session and remind you to complete the survey at the close of this event. You'll have a survey link that will pop up for attendees to complete. And after you complete the survey, you'll get access to the slide decks from today's events. Remember to tune in tomorrow for the panel of industry experts who are going to share their professional journeys and career advice. And remember now to stay after in Gather.town until about 1:30 to network. I'll be there. Hope to see you there. Thank you.